Good afternoon, everyone. My name is Sue Wenda Lewis, and we are here today for another training in our training series that we are providing virtually. I'm just going to go ahead and give everyone maybe about another 2 minutes to go ahead and log in as I'm looking at the attendees number currently. And once the 2 minutes are passed, we'll go ahead and begin the training just so that you guys are aware. And you see today's training is entitled Autism Spectrum Disorder, Identifying the Red Flags. So I'll give you guys 2 minutes to go ahead and log in. Thank you. Alrighty, everyone. Thank you for patiently waiting. I'm going to go ahead and start this webinar. So today, like I mentioned previously, we have the autism spectrum disorder, identifying red flags. Today we have two special guests that's going to be presenting this PowerPoint presentation training for us from Nova Southeastern University through the Unicorn Children's Foundation Clinic. We have Dr. Char as well as Dr. Morello, who is going to provide you guys this awesome training with great information today. But before I go ahead and pass the microphone over to them, I'm just going to go ahead and go over a few housekeeping items. This is Sue Wenda Lewis that's speaking, just in case you guys are curious, and I am here to assist and host our wonderful trainers today. All righty, so let's begin. So housekeeping items. Attendance credits, pre and post test and evaluation. So I'm going to start off with the new information that we have currently. As you guys are aware, at this time when you registered for the training, you received a pre-test, and it was 3 questions that you had to answer in order to register. In addition to this, after completing this training today, you're going to get a post test. It's going to be an additional 3 questions and a training survey of 5 questions that will launch automatically on your screen. Please complete all information and make sure that you submit it at the end of the training. Do look out for that, as this is something new that is actually taking place in our training. So there's that pre-test when you registered, as well as the post and survey once the training has concluded. So as we all know, we have been here quarantining training together as a group. All ELC Broward trainings are for in-service hours only. Once the training ends, you want to allow for at least 24 hours and for a certificate to be sent to you. It would be emailed to you based off the email address that you all use in order to register for the training today. In order to be marked as attended, you must log in on the computer or download the GoToWebinar app on your phone. You can call in. However, individuals that call in will not be recorded, or you will not receive a certificate to be marked as attended. So if you can't see the screen, that means we cannot see you and we are unable to record your attendance today. So please make sure, if you want to be counted and you would like to receive a certificate, that you go ahead and register for the training and you're actually using the GoToWebinar app on your phone. Alrighty, in addition to this, a few housekeeping items. As always, we have a few things that we like to go over before our training. So you know that the tools that we use on here, we have the chat box. We use the chat box in order to talk to each other. You can send messages if you have any questions at any point during the trainings. I will go ahead and answer the questions, or I'll let our presenters know that they have a question so that we can answer it. You can chat with myself or any other organizer. You can also chat individually with any individual that's listed on the call today, or you can chat to everyone that's on there. So be mindful of what it is that you're using when you are requesting, sending messages across our board. So that's our chat feature. In addition to the chat feature, we have the raising hand feature on the side panel. When the arrow is pointed up, that means you have a question. When the arrow is pointed down, that means your hand is raised down and you do not have a question at that given time. So be mindful of that feature that's listed on there as well. And yeah, you should be able to see my screens at all time. If you're unable to see my screen or you're unable to hear me, please do feel free to send a message in a chat box so I'm aware, or our presenters are aware, so that we can figure out what's going on. There is the handout portion. There's one handout on our presentation today. The title of that handout is listed. It's identifying red flags, I believe. And on there, that handout is available to you. Please use this time now to download that handout, because once the presentation is over, you will no longer have access to download that handout. So the handout is listed on that side panel as well under handouts. You want to click it and download it. And like I mentioned before, your certificates will be emailed to you at the end of the training within 24 hours. I believe that's Miss Morello. If you wouldn't mind muting for me, I think, or I'm not certain if it's Dr. Char or Dr. Morello. There we go. Awesome. Thank you. All right, moving along. So I'm going to go ahead and transition this presentation over to our panelists as well as our presenters. I'm going to start off with Dr. Char, and she's going to take it away. And Dr. Morello, feel free to chime in when necessary. Thank you, guys. I'm handing you guys over to great hands.
Thank you so much, Ms. Wenda. Well, it's our pleasure to be able to provide this webinar to you guys today. And before we get into the topic, I wanted to do brief introductions of ourselves. So basically, I'm a licensed clinical psychologist. I am the clinical supervisor of the Developmental Assessment Clinic at Nova Southeastern University. And basically what we do is we provide psychodevelopmental assessments, evaluations of children who are suspected of having autism, spectrum disorder, developmental delays, or behavioral difficulties. And in our clinic, I supervise the postdoctoral psychology residents like Dr. Morello, as well as doctoral psychology trainees. In addition to that, I've had a lot of experience in the assessment of autism spectrum disorder. I've worked with this population for many years now, and it's definitely something that I'm passionate about, increasing the awareness of autism. In addition, I am bilingual, so I do provide services in Spanish to the Hispanic community. So I do the interviews, the diagnostic interviews, as well as the evaluations completely in Spanish if the child prefers Spanish and if Spanish is their primary language. And I do communicate with the parents in Spanish as well for those who are not fluent in English. So that's just a brief introduction of myself. And now I'm going to hand it over to Dr. Morello so that she can give you a brief introduction about herself.
Hello, everyone. My name is Dr. Morello. Thank you so much for having us here today. I am the postdoctoral resident at Nova Southeast University in the Developmental Assessment Clinic. I work alongside Dr. Char in providing comprehensive developmental assessments. I also help co-lead their Starting Right classroom, and that includes about 5 children with developmental delays anywhere between the ages of 18 to 36 months. I am also bilingual, and I have extensive experience providing individual, group, family therapy for a wide array of emotional behavioral presentation in children and adolescents ages 2 to 18, as well as working with their families. I also have extensive experience working with underserved, marginalized population, and I'm really passionate about providing community outreach in order to increase access to early intervention. Next. So I'm going to start off by talking about who are you and what is your role. And from my understanding, you all experience these children for a wide amount of time throughout the day. And really, when the parents are not with them, you all are seeing these behaviors day in and day out. And you all can also act as well as a gatekeeper to see what behaviors are concerning, what behaviors should we be discussing with the parents that might be some sort of red flags. So your role is actually quite important, helping increase awareness in our families and our youth. Next.
Give me one moment, please.
Oh, yeah, go ahead. So in terms of what the plan for today is, we already discussed, we're going to discuss why are we here today. I'm going to provide an overview on autism spectrum disorder, making sure to touch upon what is the current, the prevalence as well as the current diagnostic criteria, providing you with plenty of examples of what that looks like. Then I'm going to hand it over to Dr. Char, who's going to discuss the early red flags of autism. I will come back and discuss the misconceptions of individuals with autism spectrum. And then we'll also discuss diagnosis and answer any questions that you all may have. So why are we here today? And here you can go on to the next slide. So today, we're going to talk about autism. We want to be able to really identify and discuss what is autism spectrum disorder. What does it look like out in the population? How prevalent is this right now? Reviewing these red flags and really just start talking about any recommendations that we can provide to our families. If you can go on to the next one, thank you. We really are here to help promote and encourage families to seek services. Again, early awareness, early intervention is really going to be key with some of our really young kiddos. And we're going to try our best, right, in our communities to help these children access the service that they require. You can move on to the next one. Thank you. Who are we serving? Over at the Mailman Siegel Center, as well as in your occupation, we are working with children, we're working with families, people, so many individuals who experience a wide array of different, concerns in their life in terms of whether it be their children's behaviors or financial stressors. It's just, we work with a very different array of population. You can go on to the next one. And these individuals, sometimes they have challenges. And as you see in these images, our children are experiencing big emotions from an early age, and this can be quite challenging for not only the child to manage, but now we have parents who are also managing their child's big feelings. And with these big feelings come also new behaviors that we're trying to figure out and solve at the same time. You can go ahead. And today, something I do want to make important is today we're really not going to focus on labeling. When we think about autism spectrum disorder, it's really not a label, it's a way to access, for these children to access services, access the help that they require in order to improve their day-to-day functioning. So we really aren't trying to label anyone with autism. Go ahead. And today, we really want to focus on how your impact, right? How your work with these children, with these families, and how that can help them out in the community. You can go on to the next one. I want you to take into consideration that the seemingly small decisions that you make every day really have an effect on the large-scale impact on the lives of the children and the families that we work with. And for some of you working with these children who have been working with them for a while and have seen them grow throughout the years, you can see how perhaps if they go to a certain classroom and they're used to a certain technique, they've been able to learn that and generalize that at home, whether it's the structure, the organization. We really are impacting these children and able to generalize some of the skills they're learning in your classrooms to the home. Go ahead. So I'm going to start off by talking about what is autism spectrum disorder. And on the next slide, I want to start discussing about the prevalence rate. So just quick true or false here. The prevalence rate has gone up. True or false? So feel free to type it up in the chat. You could put T or F. Just give you 1 minute to respond to that. The prevalence rate has gone up. True or false?
So currently, I see a lot of truth that's actually coming into the chat box, Dr. Shar.
Perfect. Thank you. Thank you so much. So go ahead on to the next slide. So in fact, yes, true, the prevalence rate has actually gone up. And this is from the CDC, the Center for Disease Control, their most recent article in 2020, it went up from 1 in 59 children to 1 in 54 now has been identified with autism spectrum disorder, according to the Center for Disease Control. And autism spectrum is about 4 times more common among boys and among girls. And then also the number of children who had a developmental screening by age 3 increased from 74% to 84%. And this is really telling us that we're moving towards earlier and more consistent screening. So as we're doing screening these children at an earlier age, we're really getting more access to services earlier. Go ahead, you can go on to the next one. So now I want to talk about in terms of what is autism spectrum disorder, what it was once considered, and you can go on to the next slide. So what are this diagnostic criteria for ASD? What was it before? So autism spectrum disorder is really a spectrum. It includes what used to be known as Asperger's syndrome, which is the more higher functioning individuals. We also used to have a diagnosis called pervasive developmental disorder, not otherwise specified, which really was just an umbrella to capture some of these behaviors similar to autism, related to autism, but that really didn't fit the criteria for autism. And what we've done collectively as professionals is we've broadened what it means to be on this spectrum. And when we've broadened that spectrum, the requirements for the diagnosis, it looks very different. Some children might be on the higher functioning, right? So they might require less support. They might be verbal. It might be of average to high intelligence and might be able to function on their own versus perhaps the lower functioning or those that require substantial those on the lower side of the spectrum, they are probably nonverbal, have a harder time functioning on their own, require support. And really, just to let you know, it appears differently from wherever you are standing. I have yet to see two individuals on the spectrum who are exactly identical. Go ahead, next. So what is autism spectrum disorder? So as we know, this is a neurodevelopmental disorder. We're really still trying to figure out in terms of genetics, if there's a genetic predisposition, is it the environment? Right now, there isn't sufficient data to be able to support either side. What we're looking at is a combination of the two, where the child in utero, as they're developing their brain, there are perhaps difficulties in that development, and then as they go into the environment, these difficulties become more prominent. And what are these difficulties that I'm talking about? We've categorized them in terms of two separate areas. So this can look as deficits in social communication and interaction, and then restricted repetitive behaviors or interests, and these are known as RRBs. And if we go to the next slide, thank you. I'm going to talk a little bit more about what do these look like. So in terms of deficits in social communication and interaction, this is a child that's not able to really reciprocate in social interaction. And when we're thinking about young children, in terms of asking them about their day or asking them about something that they did that day, or a friend, being able to engage in that back and forth is challenging for these individuals. And you'll see that conversations with them feel very one-sided, where you're asking them questions and they're very brief, they're responding yes or no, but they're not really asking about you and what your thoughts, your opinions, or what you've done. And what we also see in terms of social reciprocation is sometimes they can reciprocate, but only when it's about things that they enjoy. And I'll get to that on the next slide. But for now, I want to talk about what else they struggle with, which is initiating conversation, right? Initiating those social interactions or responding. And here we're thinking about our young kiddos. How are they requesting for things? How can you tell when this child is asking you, I want goldfish crackers? Are they grabbing the crackers from you without making eye contact? Are they able to look at you and say, goldfish, please? And really what we're seeing is that we're having children who perhaps they're not initiating those social bids. They're grabbing, they're reaching, but they're not really integrating that with eye contact, which comes to my next point in terms of abnormal eye contact or body language. And here what we're seeing is children, on the spectrum, they have difficulty with their eye contact. And this can look in a variety of ways, whether they are able to make eye contact, but it's very fleeting. So someone who maybe looks at you and then just looks away, they can't maintain the eye contact. Or someone who's not integrating, like I said before, they're not able to request for goldfish while looking at you, or show you a toy and look at your face while they're showing you a toy. We're also seeing a lack of facial expressions. Children on the spectrum, they have a hard time in terms of sharing their emotions with others, right? So when we're thinking about a child who is scared or a child who's surprised, right? We're playing with them and we're playing Jack in the Box, and we know we're winding up the Jack in the Box and it's gonna pop up and the child is gonna, they're gonna look very surprised and they're gonna look up at you. Perhaps a child on the spectrum is not showing you that surprised face. What we're seeing is a lot of extreme emotions, not really directed at anyone else. So maybe they'll be smiling at themselves, not really smiling at anybody else, or they'll be frustrated and crying and look really upset, but again, not directed at anyone else. They exhibit difficulties in developing and maintaining relationships. So now that I've pointed out all the other difficulties with social interactions, you can see why it's difficult for them to initiate, develop, or maintain a friendship or any relationship, because they're not really responding to social cues from other individuals, or perhaps they're not initiating social conversation with their peers. And what we're seeing as well, common on individuals on the spectrum, is this absence of interest in peers, where perhaps in your setting in the preschool, you'll see all the children playing in one center, and you'll have one child off to the side, kind of playing next to them, but not really engaging with them. And the child is actually perfectly fine and happy playing on their own and not really interested in joining in the other kids while they're messing around in the kitchen and they're baking and they're cooking. In terms of the restricted repetitive behavior and interest, here we're seeing stereotyped or repetitive movements. And this looks like children who are lining up their toys or their hand flapping. These could be children who are pacing back and forth in your classrooms. Maybe they're body rocking and they're rocking their body side to side. We're also seeing repetitive speech, which we call echolalia, and it's basically saying the same phrase over and over. Or they're repeating phrases that they heard. And this can be children who are seen as scripting, where they're repeating perhaps a scene from Toy Story, and they're saying that same exact scene line for line while they're sitting there and playing. Or when you're talking to them and you say, water, would you like some water? They'll say water, and they'll repeat you in the same intonation. We're also seeing inflexibility, needing routine, needing to take, for example, needing to take the same route to school every day. We actually had a client that we were testing that, he knew exactly which way was the route that they take going from home to going to school, and they knew that they passed by a specific place. And if they took any other route that morning, he would be very upset and he would start crying, and it would just be very difficult for him to start his day. I've also worked with children where if they don't get that one bottle of milk in the morning before going to school, it can throw them off completely for that whole day. So it's very inflexible. Then, as I mentioned earlier, these restricted fixated interests, so these very specific interests. And as we know, children will go through different phases where one day they'll like My Little Pony, and then another day maybe now we're liking Thomas the Train. Today we're playing with Legos for a little bit. But when we're talking about restricted, very fixated interest, is someone who's very insistent on only playing with My Little Pony or only talking about My Little Pony and giving you facts about My Little Pony. I've worked with children in the testing where they've brought out toys from their pockets and they've given me facts on the toys that they have in their hands. Or I've worked with children who are very specific subspecies of dinosaurs, and they will be in conversation with me about those dinosaurs. These are very specific interests, very restricted interests that we can't shift them away from that. So this is a child in the preschool that only wants to play with blocks, and the day that, oops, sorry, little Timmy got to the blocks first, this child is having a fit because they only want to play with the blocks and they're not able to play with anything else. Lastly, we have this hyporeactivity to sensory inputs such as noise, smell, taste, or touch. Here's what we're talking about is sensory sensitivities. And here it could be in terms of things being aversive, so they don't like it, the sensory input, or they're sensory seeking, which they want it. And I'll let Dr. Char later on talk a little bit more about that. We can go on to the next slide. So now I'm going to transfer over to Dr. Char, who's going to discuss the early red flags.
Yes, so thank you, Dr. Morello. And some of the examples that Dr. Morello brought up, I'll kind of provide more examples because we want you guys to have a really good idea of how these behaviors are manifested and how children may display these behaviors. So like we said it before, no child with autism, like there's no two children are like exactly the same with autism. So you see one child with autism, you see one child with autism. So that's why when we talk about early red flags, I want to kind of focus on what you may be seeing in your classroom with your children. So we'll kind of review some concerns that you may see in your children on a daily basis. But it's also really, really important to remember that just because you see a few of these signs does not automatically mean a child has autism. Okay, it really, really takes a skilled clinician to administer appropriate tests and really determine if the child meets criteria for autism or, something else. They could have a global developmental delay. You know, there could be other things happening. So if you see some of these red flags, it's important to note them, but it doesn't necessarily mean they automatically, you know, have a diagnosis of autism. So we're going to review some of the early signs. We're going to see some videos as well from the CDC so that you guys can see what these behaviors look like in children. So we can go to the next page. So some of the early social indicators, we're going to talk about those now. So there are certain skills that children should possess. So something like joint attention. This means that the child is directing your attention or somebody else's attention to an item that is out of reach. So you're kind of creating this triangular interaction, right? Where the child is saying to somebody else, look at the airplane. So they immediately direct somebody else's attention to an object that is out of reach, for example, an airplane. So that's an example of joint attention, but we see that joint attention tends to be limited in children with autism. So you might not see much joint attention. Does that mean that a child with autism cannot engage in joint attention? No, that just means that it's more limited. And then we also have looking at the faces of others. So we see that, you know, maybe when they're younger, they don't typically look at the faces of their caregivers. They might not be interested in other children, like Dr. Marlo said. This might be a child in the play, you know, in daycare or in the early intervention setting, preschool, that might not be engaging with other children. So they might be playing alone. Maybe when they go to the playground, they're playing with items like rocks or leaves. And also simple pretend play activities may be limited. So oftentimes you see children kind of imitate what their parents are doing, like cooking or shaving or cleaning. You might not be able to see those pretend play activities as much. And like I mentioned before, sharing enjoyment with others may also be limited. One of the things that we look for is whether they respond to their name. And oftentimes we see that they have difficulty responding to their name. So typically you would call a child, say Johnny, you would expect them to look over, make eye contact with you, you know. But sometimes you'll see that you might call a child's name if they're on the spectrum and they might not look. Sometimes they might just kind of briefly look, but they don't make eye contact. So this is something that we carefully look at. And then also, of course, you know, you might not see as much pointing as you would see typically in a typically developing child. So those are some of the skills that are some early social indicators. And obviously, if they're missing on a regular basis, you know, and over an extended period of time, then there's definitely a concern. Because some children may have a delay, but when it's, you know, obviously over an extended period of time, then this starts to be more of a major concern. You can go to the next slide. Thank you. So this is going to be a video here, and I want you to see this video.
Please, everyone, mute yourself.
All right, so here we clearly see that this person was trying to get the attention of the child, and the child was not making eye contact. She was making a lot of attempts, multiple attempts, but the child did not respond when her name was called. So this is kind of an example of what we see of them not making eye contact. So let's go to the next slide. So there are some differences that we also see in adult and infant play. So for example, like we mentioned before, not really looking at the face of another person, and abnormal use of eye contact like we saw in the video. So they're really not making eye contact with you. And you use eye contact for many things. Use eye contact to show the other person that you're responding to their interactions. You make eye contact to share enjoyment. You make eye contact for a variety of reasons. So there's definitely something that you see here during play. And like Dr. Merlo mentioned before, that failure to show appropriate facial expression. So you might see extremes like happiness, enjoyment, or the other extreme, frustration. But facial expressions like confusion, surprise, shock, those may be more limited. And combining smiles with eye contact is something else. Usually when you're playing with a child, you're looking, maybe you're playing peekaboo, you have that blanket over your head and you look at the child, you pull it down and you look at the child and you smile. So a lot of the times you might see that they have difficulty integrating smiles with eye contact. So they might just smile, but they don't necessarily pair it with eye contact. And in the literature, we see that the infants typically have a decreased smile in response to their mother. So when their child is interacting, you see that they tend to smile less than typically the neurotypical developing children. Okay, let's go to the next one, and we have another video for this one.
Would you like to explain what's happening in this video? This video seems to not be online anymore.
Oh, it's not okay. So basically for this one, this was another example of, if you can present, it's fine. It's a therapist trying to make several attempts to make eye contact, but the child still is not looking or engaging or sharing enjoyment, which is what we're talking about, that sharing enjoyment aspect with the child. So you're playing with the child, you want the child to look at you, then you want them to integrate smiles and eye contact, facial expressions, but that tends to be a little bit more limited. And that brings us to the next point about conventional social games, like I mentioned before. So maybe they're playing peekaboo, but the typical response is that you lift up the blanket, and then the child will go ahead and pull the blanket down and smile, and then they're going to look at you and kind of like stay there and smile as a way to request for more. They might say more, or they might pull it over their heads, right? So you might see a decreased involvement in social games. So one of the things that we do when we evaluate our children is that we play peekaboo to see how they respond. And we have the towel over, or sometimes we use our hands, depending on how the families are used to playing peekaboo. And you would want the child to move your hands and smile, and you would want them to pull the blanket down and look at you and kind of initiate that they want more. But that's decreased in individuals with autism. The same thing with social turn taking. Many of the times it's hard for them to understand that turn taking aspect, because we go into the theory of mind where it's hard for them to kind of think about what the other person wants or needs. And then problems imitating gestures. So gestures is something that we look at to see if they're able to point, if they're able to use their hands to describe an object. Do they use their hands to communicate? Oftentimes, they might have a speech delay. Does not mean that every child with autism has a speech delay, but if they have a speech delay, typically children will rely on gestures to communicate their needs and wants. But if a child is delayed in speech and also has difficulty communicating with gestures, it's going to be harder for them. And they might engage in behaviors like crying and temper tantrums because it's frustrating to not be able to communicate what you want, what you need. So oftentimes they have difficulties, initiating communication. So typically you would want a child to maybe approach another child in preschool, but this child most likely might prefer solitary play and not really initiate. And if other people or other peers initiate an interaction with them, they might not respond and they might not be able to engage in turn taking, especially if they're playing with a toy that they really like, which is kind of their special or excessive interest. If another child comes and tries to play together and take turns, the child with autism might have a really difficult time because of their excessive interest. And I've seen this happen, when we have children very, very interested in cars or trains or, something that they're really into. If somebody else tries to take it away, it's very difficult for them to understand that. And that's why we mean, in terms of the excessive interest, how is it interfering with their everyday life? Because children have interests, right? They like Thomas the Train, they like cars, they like this. But how is it impacting their everyday functioning? Is it impacting social functioning? Some children that we see sometimes have like this really intense interest in cars, and they have to sleep with the cars. They have to wake up with the cars. When they go to preschool, they have to have a car in their hand. So those are examples of what we mean by excessive interest. So let's go to the next slide. So we see some differences in the way they play. So when you see a child, you can tell a lot by the way that they're playing with objects. So visual inspection is something that we look for. So what does this mean, visual inspection? So pretty much this means that sometimes you might see a child get an item and they might put it really close to their eyes, where typically children don't really have to put it very close. And they might even put the item next to their eyes and kind of look at it from the corner of their eyes. That's what we call peering. So if you see the child is getting an item and putting it very close to their eyes, sometimes you might see they take items like a car or a truck and they kind of tilt it over to look at what's under, like the letters sometimes. So this is kind of a different way of playing with items. So we look at how they're playing with the items. Are they playing with the items functionally, the way that they're supposed to be playing? For example, a car. They pretend that they're racing the car, or do they kind of play with the wheels of the cars? So are they focusing on certain parts of the object rather than the whole object, the way that they're intended to play with the object? You might see that there's less, they tend to not explore the environment as much. And they prefer at times sensory motor play. So what does this mean? They might really like playing with water. Sometimes I see the parents will tell me, this child loves water. They want to touch water. They want to play with water. And sometimes they might have a sensory aversion, so they don't like the sensation. And we have a slide talking about sensory seeking and sensory aversions as well. But oftentimes we see that taste, they might put the items in their mouth, like mouthing. So that's something that we might see. And mouthing might be, something that children, maybe a 1-year-old do, even 2-year-olds. But once they start to get 3 or 4 and they're still mouthing objects, that's one of those red flags. Smell also. This is something that we see. Sometimes you'll see that they smell things, not necessarily food. And even with food, sometimes they might smell things before they actually consume the foods. Things like Play-Doh, they might really like the sensation of Play-Doh or slime. In other cases, they won't, but they might prefer those that play that involves those sensory motor aspects. There might be also fewer relational acts. So they might kind of play by themselves, like I mentioned before, not really involving or initiating. So they might see a group of children playing, but they might not approach that group of children. The stereotypical behavior, this is more of like the lining up the toys, like you see in the picture right there. When you see that, you're like, oh, that's a different way of playing with the toys. They might stack up blocks. They might line up toys like you see in the picture. Those are kind of different ways of playing with items that can, obviously warrant attention if they're doing this along with other behaviors. And then maybe, the way that maybe they have we use a bubble gun to kind of play with them with bubbles. And instead of them actually being interested in the bubbles, oftentimes they're interested in the little propeller that our bubble gun has. So they're not necessarily interested in the bubbles, but in the propeller of the bubble gun. And that's what we mean by really not engaging as much time in functional play. And then obviously, sometimes they might use objects repetitively. You might see things like them playing with a certain car or a certain truck in a repetitive way where they're doing the same thing over and over again. We can go to the next slide. And then the difficulties with social interactions. Here, we can see the difficulty with imitative play, like I mentioned before, and imaginative pretend play. So this typically begins around age 2. So it's expected to kind of be there by age 3. But like I mentioned before, that pretend play tends to be limited. And what is it that we see? What are those red flags that we're talking about? So if they play with non-toy items, what do I mean? I mean that if we're outside playing playground, are they playing on the slide? Are they, playing in the swing? What are they doing? What you might see is that they're playing with rocks. They're collecting rocks from the ground. They might be playing with strings. These are non-toy items, right? Or sticks. I've seen children where they go in playground and they start kind of getting the leaves from the trees or even the grass, and they start shredding it. You might see this with soap. Sometimes parents will say, oh, yeah, they like to get the soap and kind of pick at it. Or they might pick at the stickers in labels. They might pick out stickers and other things. So I remember a child who was picking, they had a sofa, and it was, I think, microfiber, and it was kind of peeling, and the child would constantly pick at the furniture until it was completely, there was a complete bald section. So that's what we mean, like non-toy items. What is it that they're playing with? And the unusual ways, like I mentioned, stacking toys, spinning the wheels of the cars. If you see that this is an ongoing thing, obviously it's a red flag. And pretending to talk on the phone or feed the baby. We want to see that behavior, right? Because you would typically have a cell phone, a fake cell phone, and they would typically put it next to the ear, say hello, and then you might say hello, and then you're pretending. But with autism, there is this rigidity that Dr. Morello was talking about in terms of that lack of flexibility in their thinking. So it's rigid. It's a rigid thinking pattern. So I remember assessing a child, and I pretended that this cylinder block was a car. And I said, oh, look, this is a car. And I pretended that I was racing the car. And he got very upset, and he said, that's not a car, that's a block. And then I said, no, let's pretend it's a car. And he was very, very upset because he said, this is not a car. Because in their mind, if they've encoded things in a certain sequence or in a certain way, it's difficult for them to kind of wrap their head around it in a different manner. So that's what we talk about, rigidity in their thinking patterns. That's why, obviously, when children get older, they might have difficulty with abstract thinking. That means like they might not understand sarcasm. They might not understand jokes. You know, I've evaluated teenagers, and I'll ask them things like, oh, do you know what this means? Like, when somebody tells you when pigs fly, do you know what that means? And then I've gotten answers from individuals like, pigs don't fly. Like, what do you mean? So that it's hard for them to understand idioms, metaphors. And then like I said, you know, pretending, like the more complex imitative pretend play, like playing house, school, doctor, that tends to be more limited. I remember when I was I was observing, doing a class observation, and the child was, I've done observations in typically developing classrooms and, you know, classrooms with children with special needs. And I remember I had to do 2 observations in one day, and one was in a classroom with typically developing children. And then I think that their age was 3, like they were like 3 or 4 years old. And the little girls were playing like they were mom, and they pretended they were pregnant, and they put like something under their clothes, and they were like walking like they were pregnant. And I was like, wow, you know, it's so different sometimes when you see the play in a typical developing child and versus autism. Not that they can't, you know, play, but the complex imitative pretend play is different when their autism is not present, because they have the ability to have that more abstract thinking. Let's go to the next slide. Okay, so now we're going to talk about a little bit more in detail about what Dr. Morello mentioned about the RRBs, or these are the restricted repetitive behaviors. And like she mentioned before, when we diagnose a child with autism, there needs to be 2 areas where they're having difficulties. They need to have difficulties with social and emotional, you know, problems, and then the restricted repetitive behaviors. That's what, and the way that this looks is they might engage in hand flapping when they're excited. They might engage in finger posturing. So you see here the third picture, the little boy, you see his hand, the way it's positioned, it's different. And that's what we call hand or finger posturing, because sometimes you might see that they position their fingers in an odd way when they walk. So that's something that is a red flag. Toe walking is also a red flag. Does that mean that every child with toe walks is on the spectrum? Absolutely not. And that's why it takes a skilled clinician to see everything. So we conceptualize everything. We're like, okay, this is happening, but you need to have a certain, you know, all of these behaviors to really meet diagnosis for autism. So things like you might see them spinning, you might see them jumping, rocking repetitively. You might see them if they're in the classroom, walking or running back and forth, pacing back and forth, back and forth. So those are some of those repetitive motor movements that we talked about. And like we mentioned before, with the visual inspection, looking out of the corner of their eyes or getting very, very close to the objects. You might see them opening and closing doors or flicking lights on and off. So this is something that's common. They might come in the room and they might just flick the lights on and off, on and off, on and off. Or if they're playing, you know, if there's like a cabinet, they might, you know, when I've done evaluations and I've done school observations, there might be like a play kitchen area, and instead of kind of cooking, you know, in the kitchen, they might just kind of open and close the cabinet doors repetitively, over and over again, instead of actually playing like if they're cooking or pretending to play. So they might be very specific and repetitive in the way that they play with things, even though there might be other things inside to play with. They might just engage in repetitive behaviors like opening and closing the doors, flicking lights on and off. And then when they're playing with objects, maybe they're playing with a doll. They might just play with the doll's hair, or they might, you know, flicker the baby doll's eyes on and off, like repetitively. So that's definitely something that we want to look at. So how is it that they're playing with toys? it's something that is very interesting and you want to keep an eye on, of course. So we can go on to the next one. Okay. So like Dr. Morello mentioned, and I mentioned the interests, when we talk about special or restricted interests that are abnormal in intensity. So it's not about just liking trains and liking cars and liking Peppa Pig. It's about if they like Peppa Pig, they have to watch Peppa Pig. And if they repeat, maybe they're watching on YouTube and they repeat the same video over and over again. I had a child who I evaluated and he was really into Peppa Pig, and he actually even spoke in the tone of Peppa Pig. I think Peppa Pig is from England. So the child, his parents were Hispanic, but if you heard him speak, you thought he was British because he would repeat lines from Peppa Pig and he would say something like, "Oh, no more lovely dinners." Obviously, he did it much better than I do. But this was something that he kind of repetitively said, and he repetitively kind of engaged in scripting, which means repeating lines from TV shows. And I was like, this must be something that he hears. And yes, it was from Peppa Pig. So he had to watch Peppa Pig. He spoke like the main character, Peppa Pig. And sometimes you might see this happen a lot, where they'll copy the same accent as the character that they like. So it was very interesting, and he spoke like he was a British, boy, and it was kind of fascinating. And the people at school asked the mom if his dad was British because they heard him talk like that, and his mom's like, no, he's not British. He just likes to talk in that accent. So when they're younger, you might see that they're really interested in letters. This is a big one. Numbers. So everything that they like is letters and numbers. The parents might say, oh yeah, they can count the ABCs, and there may be two. And obviously if there's some other things that they're doing, they might say, oh, that they can read, the child can read and he's 2 or 3. So let's tell me more about that. Because obviously this is an intense interest. I've evaluated children who know the alphabet in Korean, in Portuguese, so they learn the alphabet in different letters. And I mean, they learn the alphabet in different languages. Obviously, this is something that is, kind of atypical, because you wouldn't technically learn the alphabet in different languages. That's because you're really interested in letters. Same thing with numbers. Everything that they want to play with involves with numbers. So this is something that you can, be aware of. When they're older, they might be interested in unusual subjects like license plates, and I've had children who are interested in different kinds of sharks and fossils and macrophages and things that they blow my mind sometimes, because I was like, wow. And when I talk to them about it, they don't really pick up on the fact that I'm really not interested in talking about it, but because it's their interest, they're going to keep talking about it over and over again because they're unable to pick up those social cues a lot of the times. So that's why it might, their special interest might interfere obviously with friendships, because if you want to establish a friendship, the other person has to take a turn. You have to take a turn when you speak. And if you only speak about things that you like, the other person is not going to be interested in talking to you anymore. But this is an area where they have difficulty with. Let me see. So yes, something they might be very narrow, but baseball statistics, Civil War, and things like that. So we can move on to the next one. All right. So when we talk about sensory hypo and hyperstimulation. So give me 1 second so I can drink some more. So with autism, you might see that certain children are overstimulated by the environment. So what does this mean? This means that they have difficulty filtering out what's important in the environment, and it's too overwhelming for them to process. So if it's too overwhelming, they're going to have a difficult time regulating that sensory input from the environment. So what is this going to look like? This might, obviously, if there's a loud noise like sirens, alarms, fire alarms, sometimes, with children with autism, you have to kind of give them a warning if you know it's a drill happening, so they can kind of get prepared, because transitioning for them is difficult. So if they transition from one activity to another, especially if it's from a preferred activity to a less preferred activity, that's going to be difficult. So giving them time to kind of process and giving them, that goes into like the treatment, like visual stimuli, that can help them understand what's coming next, might help them with the regulation. But this might look like, if they're overstimulated, they might cover their ears. So they might, if there's really loud, they might cover their ears. Oftentimes I see children who have like maybe an aversion to loud noises, even like toilet flushing or the vacuum or the blender. So they'll cover their ears and they might start crying because it's too overwhelming for them. The other thing is that a lot of the times when they might be picky eaters. So oftentimes you'll see that they're very, very, very selective about the foods that they eat. And it might be due to a texture, it might not. But they tend to be really, really picky about what they eat. Not everyone, of course, but they tend to be, certain textures they don't like. Maybe they don't like solids or the vice versa. But they have difficulty regulating that sensory input from the environment. They can be light. Maybe they're very sensitive to light. So a lot of times you see parents, they might say, yes, when they wake up, you have to gradually expose them to light because it's very bright for them if you just kind of wake up and turn on the light. Another thing is that they might be, their hearing might be more developed than other children. So I've had children I evaluated where the parents would tell me that the child knows when the train is going to pass by, so they live near the train. So the child can tell before anyone in the house can hear the train. He was able to hear the train before anybody else, and he knew the train was coming. And then the parents were like, how is it possible that you can hear? We can't hear it. And sure enough, every time he told them the train is about to pass, the train, was about to pass. And the train did pass. So that's what we kind of talk about, heightened sense of, smell. Sometimes certain smells, you have children, the parents, when they cook, there's certain smells that really, really bother them. So they have to kind of figure out a way to cook, maybe put the child in a different room because the smells can be bothersome. So obviously all of those sensory aspects play into it. And then we also have the children who are understimulated. So what does that mean? That means that they need extra stimulation from the environment. They need that extra stimulation to help them attend to the, events in the environment. So what is this going to look like? So here, they're going to seek the environment for that sensory input. So you might see they're touching the walls repetitively. You might see they're touching the floors repetitively. You might see that they mouth things. You might see that they like the sensation of slime, water, Play-Doh, and they like to be touching different textures. If they're overstimulated, obviously they're going to avoid certain textures like sand, Play-Doh. They're going to avoid those. And that's why in therapies, you expose them to things that they don't normally are exposed to because they don't like it. And you might start with having them touch sand, Play-Doh, things like that. But if they're understimulated, they're going to seek that in the environment. So they're going to mouth things, like I said, touch textures, because they're seeking that stimulation from the environment. So that's what we call sensory seeking behaviors. And then when they're overstimulated, we call it sensory aversions because they try to avoid those sensations because it's too overwhelming for them. So we have, you know, the auditory component, tactile and taste. That's why that component of being a picky eater is something that we often see with children on the spectrum because they might be very specific, and this is where that rigidity comes into play, where they have to have a certain brand of snacks, and they know the brand, and they know that if it's not Tyson chicken nuggets, they're not going to eat it, even if you try to, like, you know, kind of fool them. They're not going to be fooled. If it's, you know, Cheerios, maybe it has to be Cheerios. It can't be any other brand. So they're very specific about what brands, and if you really can't lie to them. And I see this very, very, very often, where they're very specific about the brands. Same things with like the clothing that they wear. A lot of times parents will say they don't like tags on their clothes, so we have to cut them. Or they don't like wearing jeans. They only like wearing this texture, or their blanket has to be this texture. So those are all things that you might encounter or that parents may report. So obviously, once we have all of this information about what the areas they're struggling with, like the, you know, areas of social communication and what those restrictive repetitive behaviors are, that included the sensory component, the rigidity, that inflexibility, then we can make a diagnosis. Once we've evaluated them, once we've done an assessment, then we can determine what is happening. So for the next one, you can go to the next.
You have a question, Dr. Morello. Someone wanted to know that if the overstimulation, understimulation affects when and how often the child eats.
I'm sorry, what was, I couldn't understand.
If the child being overstimulated or understimulated affects how often, how many times the child usually eat during a day, does that have any impact on that?
On how they eat, is that the question?
Yeah.
Yeah, it might, sometimes it might be a situation of the transition. I've had children where if they don't eat with a certain person, they, you know, like a certain therapist, they refuse to eat. And obviously, if they're very overwhelmed, they might engage in crying, they might engage in temper tantrums. So it's something that may happen, obviously, and doesn't mean that it can happen. But you would have to see like the antecedent, what's happening before that, to really determine if that's really the trigger, if that makes sense.
And another question was in regards to a child that only eats solid food.
Uh-huh.
Does not eat solid food. Is that sensory associated as well?
Yeah, it could be sensory if they don't like solid foods. So that's why we always ask about their eating habits, because sometimes they'll refuse to eat solid foods, and that's why in that situation, especially if they're nutritional concerns, we definitely will recommend a feeding therapy, so that they can do a feeding evaluation to determine what the cause is and determine the best treatment for them. So you can skip that one because I don't think you can play that one. So you can go to the next slide. This was the video from before, but I guess you guys got it. So this was a video from before, but I'm glad you were able to play. So here you see how the child kind of responded by kind of smiling, but he didn't look at her and he didn't smile at her. So he didn't share that enjoyment with her. So can you go to the next slide that says misconceptions of ASD? Yes, so now for this section, Dr. Morello will go ahead and
Yeah.
take over and discuss the misconceptions.
All right. So in terms of misconceptions of ASD, and you can go ahead and go on to the next slide. So one of the common misconceptions is that many children with autism have intellectual deficits or delays. And in fact, this is not true. A lot of children on the spectrum are of average intelligence for the most part or above average. So it's important to note that just because a child has autism doesn't mean that they're going to end up with an intellectual deficit or delay. Another misconception, children with ASD cannot make eye contact, and the ability to make eye contact rules out the possibility of ASD. And from what I was talking about and what Dr. Char was talking about, definitely we want to see whether or not the child is making eye contact with us, especially when you saw in that previous video of the mother addressing her child, but we want to look at the quality of the eye contact as well. So we don't want to just say because they can't make eye contact with us, they're on the spectrum. Obviously, we take into consideration a variety of behaviors, but we want to make sure that you know that there are children who can make eye contact who are on the spectrum. It's just fleeting. It's not maintained. They have a hard time keeping eye contact with you. It's very brief, and it's not coordinated. It's not in conjunction with their speech or with their body language. Another common misconception is that repetitive and ritualistic behaviors, so these are like the body rocking, hand flapping, and so forth, are diagnostic indicator of ASD. Therefore, a focus of therapy should be to stop them. So this one, in fact, is not true. A lot of times these repetitive or ritualistic behaviors such as flapping, pacing, rubbing on certain textures, this could be self-soothing for a child on the spectrum. It could be very calming for them. And we don't want to just go ahead and remove these skills that they've learned to soothe themselves. And obviously there are other more perhaps disruptive behaviors that the child may be exhibiting while a child who's on the spectrum may be exhibiting that would be better to address. And you can go ahead into the next slide. Thank you. Another common misconception is people with autism cannot do much of anything functional. And this one really breaks my heart because a lot of individuals, especially who might not be familiar with autism spectrum, or they might only be familiar with those who are lower functioning, have a hard time understanding that although their child cannot be maybe the next cheerleader or the next like popular jock, or even perhaps the next Bill Gates scientist person, they still have a lot of capabilities. And in fact, individuals on the spectrum, they have strengths in their visual abilities that some of us do not have. I've read about individuals on the spectrum who are in Hollywood, who are actors and actresses. I've heard of individuals on the spectrum who are really great designers because they use their strengths in certain areas, whether it's about human behavior, because they learn about certain scripts, they're able to act, or perhaps they are better visually. So they actually are very capable individuals. Another common misconception is people with autism do not build relationships. And in fact, this is not true. We know individuals with autism form relationships with their caregivers and their family members. And in fact, some individuals on the spectrum who are higher functioning, which means require less support, they are interested in having relationships with other people, whether it be friendships or intimate relationships with a partner. Some of them even go off to get married and have a very successful married life because they're so familiar with the person's likes and dislikes that they learn about their partner. And they may even at times be better at reading how the partner is. It's almost like overcompensating for their difficulties. They actually end up being a lot better at recognizing when their partner is upset and so forth. You can go ahead to the next slide. I'm going to go ahead and hand it back over to Dr. Char, who's going to continue to talk about diagnosis and what that'll look like on our end when a child has been referred to a psychologist.
Thank you, Dr. Morello. So yes, so basically when we evaluate a child, we will determine, what, if there is a diagnosis, if it's autism, if it's a delay, we determine what is happening to be able to provide the best recommendations for the child. So like Dr. Morello mentioned before, the idea is not to just label a child, right? That's not what we do. We have to provide a diagnosis because a lot of the times the insurances don't cover the services that the child needs unless they have a diagnosis that said it's medically necessary. So once we, our battery pretty much, looks at their social emotional functioning, what the everyday living skills are like, and their cognitive functioning is to determine what the diagnosis is. But the process so what we do is pretty much, you can go to the next slide. What we do is a private evaluation. So the process of what that looks like is that we don't share the report with anyone else. The parents have the option of sharing the report if they like to. We obviously encourage them to share the report with providers, with teachers, with the school, to be able to access services and inclusion in the autism community, as well as therapeutic services. But it's different than what the evaluation that the school typically does, like Fiddlers, which is more about the educational setting and the educational goals that they need in the school. So our evaluation is completely private. Oftentimes we have clients who maybe want a second opinion or want a evaluation because the insurance is asking for a certain diagnosis. So that's what we do, and obviously we provide a diagnosis if there is, and then that will give them access to services like occupational therapy, speech and language, applied behavior analysis. And obviously this definitely helps to clarify any frustrations. It brings clarity to challenges, frustration that arise, and the parents finally can know, yes, it is, or it's not. And this is the plan. Once they have the evaluation with us, we recommend certain, we have certain recommendations for each child depending on their results, and they at least have a treatment plan to go forward and have answers going forward. And I think that's the most important part of what we do, providing those answers that parents desperately want. And sometimes it takes a lot to be able to take the child to get evaluated because, so many factors like stigma and like what people are going to say and like, but it's definitely something that we try to do our best in providing those families with the best care that we can. And obviously always, understanding where they are in the process, because they'll be at a different place in the process, but at least getting those access to services like early intervention, which is so crucial, and the research points to this. It's really crucial for us to be able to help those families and children. You can go to the next slide. So when you make a referral as a teacher, obviously, you want to kind of stick to the facts. And if you see any of these concerns, in a child, what you should do is speak to your supervisor, whether that's the principal or the ESD specialist in your school. But you should always consult with your supervisor and saying, look, I've noticed these behaviors, and just be specific, It's not specific to say, I think this child has autism, because only a licensed psychologist or neurologist or medical doctor can provide a diagnosis like that. So obviously I'm sure none of you do this, but you never want to say to a parent, your child has autism. Because we as psychologists can't even say that until after we've evaluated the child. So if you do suspect there's certain red flags the child is demonstrating, the proper protocols to speak to your supervisor, and then kind of have a discussion about whether you want to invite the parents and have a conference to communicate your concerns. And obviously, when you communicate your concerns, you just want to be specific. Oh, I noticed, the child is doing X, Y, Z. And I was just wondering, I wanted to get more information if the child demonstrates this at home as well. But you should clarify that a full evaluation is recommended, to determine what is happening with the child. And then, of course, you make an appropriate referral, whether it's to, any provider. We do the assessment, so we'll be happy to help any families that you guys have. And we are licensed clinicians. We do have doctoral trainees and postdocs that do help us, but we are the supervisors, so we supervise all of the cases. And we definitely are able to help those families. And you just got to remember that a lot of times parents can be very sensitive to the word autism. So you don't want to really, say that word. You got to be really, really careful when you're kind of speaking with a parent who has concerns, or, when you have concerns. So you just kind of, when obviously you'll speak to your supervisor. And as a team, you can kind of say that there's some red flags for developmental concerns, which is more appropriate. Sometimes you don't want to say autism because that can throw off many parents. But that's kind of the way that it should be done. Can you go to the next slide? So this is our contact information for our clinic. This is the email that parents can write to if they're interested in our clinic. And once we receive the email or receive a call, our patient access coordinator will let them know the process for an evaluation. But if any parents are interested, we are more than happy to help those parents out. And I think you can go to the next slide. Any questions that we didn't answer? I know that this is a lot of information, and we definitely condensed it because, I could probably talk for hours about autism and red flags, but we tried to condense it and make it as simple as possible for you guys to get the main points. I'll just give you guys some time to type in questions if you have any, or
So one question that came in says, are there level of autism difference in autism versus Asperger's syndrome?
So, like Dr. Marla mentioned, before they had Asperger's in the Diagnostic Statistical Manual, which is what we use to diagnose, Asperger's is no longer a diagnosis in the DSM-5. So now it's covered under the umbrella of autism. So maybe if they were Asperger's before, they might be on the spectrum, but more higher functioning on the spectrum. So there are different levels. We have level 1, 2, and 3. Level 1 means it's kind of more mild, so they require support. Level 2 means that they require substantial support, so it's a more moderate. And then more severe presentations are level 3, and that means that they require very substantial support. So you have level 1, 2, and 3, and depending on how they present, we will assign a severity level.
Thank you. Another question that came in is, how can we help a child who was diagnosed with autism and the child is not currently receiving any services or therapy?
So parents usually are the ones that have to initiate that. So, if they don't have a diagnosis, you said they are diagnosed, but they haven't received services, correct?
Yes, that's correct. How can they assist them?
Yeah. So, if it's something that you can do with your supervisor and kind of mention to the parents, I was wondering if they've been able to give you any resources about services that are being offered to the child, and maybe you can kind of have that conversation to kind of see why sometimes the insurances are not covering, so the parents can't afford it. So there are different scenarios as to why it might not be happening, but you can have a conversation with your supervisor, maybe have a conference to kind of get more information as to why it's not happening. And of course, once they have an evaluation, they recommend certain therapies. So maybe they haven't received like a full evaluation like we do. So I know the neurologists will sometimes do an evaluation and they'll kind of put in 2 or 3 recommendations. But if they want a more in-depth assessment and more in-depth recommendations, we would be happy to help them.
Thank you. In addition to this, I will add, we do have the inclusion specialist at the ELC that you all can contact in regards to children that you are experiencing challenges with or may have a diagnosis and you don't know what exactly to do next in the classroom. You can contact your inclusion specialist or our manager, Debbie Kate, and she would be able to direct you in the path to receive further information on what to do. So another question was, how do you talk to a parent, I believe, that is in denial or who doesn't know it yet?
Yeah, so that's where you would have to speak to, the supervisor or the specialist in your school so that you can have a conference with them to kind of explain what your concerns are. Yeah, and that's where I would say we've noticed these behaviors and be specific about it. We've noticed the child tends to prefer solitary play. We noticed that they're not really playing with the other children. So be very specific when you have this conference rather than saying, autism, and refer them to get an evaluation. Obviously, if they're in denial, like I mentioned, the parents are going to be at different stages, right? So you can offer resources, but it's really up to them to be able to kind of go through the process. And it's difficult for every parent, of course, but it's more difficult for certain parents. And you can present the information as a way that you have the best interest of the child in mind, right? So you can come about it in that sense where we want the best for your child. We're noting that he's struggling in these areas. So we were wondering how we can help you help your child. And sometimes that definitely will open the door for them to be more receptive rather than you coming, because I think oftentimes parents, when they're in denial, they're kind of they kind of know what's happening, but it's hard for them to process. And they're constantly being kind of told of what the child cannot do. And coming at it from a strength-based approach where, yes, he has all of these strengths, and we're so glad to see that. However, we notice this. So how can we help you help your child? And taking that approach usually has positive feedback.
Another great comment to add in regards to this, if you don't mind, is that we also administer to our school readiness kids the ages and stages questionnaire. And sometimes when you talked about, focusing on the areas where that child is excelling, that ages and stages questionnaire can actually help lead into that conversation.
Absolutely. And that can provide some information because that's information that the parents fill out. So they're kind of acknowledging, what the concerns are there.
So it says, what happens if a parent can't afford to pay? Where could they go? I'll let you answer. I'm believing they're referring to the services, the specialty services.
So if they have a diagnosis of autism, most insurances will cover the services like ABA, and oftentimes that's why we get clients that come in because the insurance is, required every year. So we have to provide a diagnosis for them to cover. So most, and Medicaid covers most, but most insurance companies also cover the services if you have a diagnosis of autism. Obviously, I don't know what the situation there might be, but if they can look into their insurance to see what, the benefits are. If they can't pay, if the insurance doesn't pay, then they might have to pay out of pocket. But most insurances, if you have a diagnosis, will pay for the services. And if you have Medicaid, they will cover the services.
As well as if you go through the Early Learning Coalition and our referral process, some of those services should be covered as well. Lastly, a question that I had here was, is autism due to vaccines, or is that a myth?
So that is a myth. There hasn't been research that suggests that the vaccines cause autism. So there's been a lot of information, in the internet. There's been a lot of information, but that has not been, the research has not suggested that the vaccines, are what's causing autism. Because then how do you explain those cases where the child is not vaccinated and they have autism? So there is a lot of information about the genetic component of autism, and there's a lot of literature that is coming out how it may start in utero. So that can kind of explain that.
And I believe that's all the questions that we have for right now. If there's any more questions, please feel free to type them in the chat box. If not, I believe this is the end of the presentation. Keep in mind the post questions will appear after you exit out at the end of this broadcast, in addition to the survey with the questions on there as well. Did you guys want to add any additional information before we conclude the training today?
No, I just wanted to add that the evaluations that we do in our clinic for the families are completely free, so they don't have to pay for the evaluation. So if they would like to refer clients, that aren't able to pay for an evaluation, oftentimes that is one of the barriers to getting services early on, because sometimes they have to, they don't have the money for it, or sometimes they might have to wait to do the evaluation to fillers, and that might take a couple of months. So if they are interested, they can call our clinic. You can give them our information, and we can definitely help them, because this has helped a lot of families who aren't able to afford it. And it's really, I think, a really nice thing that a lot of parents are very grateful for, because oftentimes it's a very expensive evaluation, and to be able to do it and without paying anything is definitely a blessing for many of them.
So Dr. Char and Dr. Morello, I do thank you guys so much for coming in and presenting this training for us today. There's a lot of thank yous, and it was excellent information, and the training was great that I'm receiving in our chat box.
Aww.
Thank you. Thank you, everyone.
Thank you very much. Thank you very much for participating and for listening and staying with us throughout the whole presentation.
Keep in mind that the handout is on there that the Dr. Morello and Dr. Char provided for us today, identifying red flags for autism training. Do download that handout before the broadcast end, so that you have that great information there to continue on using for days to come. Thank you, thank you. So many thank you, so many great information. They really, really enjoyed this training.
We are very happy, and that's what we hope, that it's informative and that it offers new information that can help families.
Awesome. Thank you so much, ladies. Thank you. Thank you. So I'll stay on the line for another 2 to 3 minutes so you guys can download the file, then I'll end the broadcast. You guys have a great rest of your day.
Thank you. You too.
Thank you.
Thank you for
having us.
Yes, absolutely.
Alrighty, guys.